Hello, can you hear me? Excellent. Sorry about this. Hello, welcome everyone. Good afternoon. Apologies for the technical issues. So I'm Cassandra Ng. I'm a consultant geriatrician with an interest in geriatric oncology, leading the Oncogeriatric service at Wythenshawe Hospital in Manchester. Thank you for coming to this webinar on the series of education on the care of older patients with cancer. Today is the second of the series of webinar looking at the role of the multidisciplinary team in oncology services for older adults. We've got a line of excellent speakers who is hopefully going to provide you with more information around the possible roles of each individual MDT with regards to improving the care in older cancer patients. So I would encourage you to post any questions along the way. We'll take questions at the end after our case discussion. So please do post your questions along the way when you've got them. So without much ado, I'll just introduce the first speaker. The first speaker is Helen Bowker, who's an occupational therapist, but also a trainee ACP. And she's going to come to talk to us about fatigue management. Over to you, Helen.
Thank you, Cassandra. Okay, so as Cassandra says, I'm an occupational therapist with worked in oncology for quite a long time. So we're just going to have a talk on fatigue, if that's okay. There we go. Sorry. Technical stuff is not my forte, so I'm sorry about that. So what is cancer-related fatigue? So it's a common, persistent and subjective sense of tiredness related to cancer or to treatment for cancer. It's often reported as the most frequently experienced and actually the most distressing symptom for people with cancer. There are international guidelines which advise that fatigue should be assessed at the start of a patient's journey and at regular intervals following the cancer journey. The recommendation is that no one fatigue screen is used. There is lots of them out there that are available to clinicians. But they do advise that patients who score higher levels of generally 4 out of 10 or 40 out of 100 or higher should have further assessments and tailored interventions with specialist professionals. So fatigue versus tiredness. Cancer-related fatigue differs very much from being tired after a busy day or a bad night's sleep. Cancer-related fatigue is not proportionate to the recent activities that an individual might have undertaken. It's persistent and can pose a significant barrier to participation in valued occupations, and it's not relieved by resting or sleep. From an occupational therapy perspective, activities of daily living is everything that we do from the minute we wake up to the moment we go to bed. And people with cancer-related fatigue will kind of say that the fatigue can be overwhelming, that it's absolutely exhausting just to do something simple and mundane as making a hot drink, or if you consider how complex an activity like having a shower is, that's just exhausting, and people stop doing valued activities. It's also a very difficult thing to pinpoint. There's no one underlying cause of fatigue, which is related to cancer. There's often the reasons that are underpinning are very complex and multifactorial. It can be a result of multiple medications with side effects which could include fatigue. Not eating, so nutrition can be an issue. You've got no energy in, so no energy to go out as well. It could be as a result of your treatment, depending on where you are in your regime of the disease. It could also be the disease progression, something like that. And it takes a lot of investigations to kind of rule out maybe the more medical things that can be corrected to look at what actually is the true cause of that cancer-related fatigue. So often cancer-related fatigue in the older frail adults, cancer is reported by 80 to 90% of patients undergoing treatment. And for the older adults, it can be, I think there's statistics out there that say that 50% of older adults, before they're even diagnosed with cancer, it can be very much a precursor to frailty and very much the precursor to a cancer diagnosis. It's also perceived as being just a normal reaction to the cancer and an inevitable part of somebody's cancer-related journey. Often patients have very different priorities to cancer treatment. The older adults will prioritise quality of life very much over the longevity of how long the prognosis is going to be. That they'll see that as more important as independence, and the quality of life is more important than survival. Elderly patients who are particularly frail are at increased risk of treatment toxicities across the board, and at least one frail older adult will experience at least one treatment toxicity ranging from moderate to actually fatal. Fatigue is the most common experienced treatment toxicities, and there are actually quite a lot of barriers to it being managed effectively. So a lot of older adults will underreport fatigue, as it is often seen as a normal aging process, and we've also got the perception that it's an inevitable part of the cancer journey. They often feel that their fatigue is not important, and that the priority is for the treatment of the cancer. Other symptoms like nausea and vomiting are often perceived as being more debilitating than fatigue, and that often isn't the case. It's, nausea and fatigue can be fairly easily treated, but nausea and vomiting can be fairly easily treated, but fatigue not. Older adults may not also volunteer the information about how the fatigue is unless they are specifically asked by a health professional, which could suggest that the things like EPROMs and other online surveys that we do, that they do not address the multifactorial dimensions of nature of the fatigue. And also with older adults, they don't always have access to the technology that requires that kind of thing, or that they just are not interested in filling in online surveys. There is a lack of education and confidence around healthcare professionals a lot of the time in understanding fatigue and actually having the confidence to ask the question, and the confidence of what simple interventions could help individuals. There's also, for an outpatient perspective and for an inpatient perspective, there's also a lack of time due to the busy clinics and high caseloads, and often that opening that bag of worms that fatigue can create is just one thing that it takes a lot of time, and it's probably one of the things that gets left behind, really. So the effects of fatigue are multifactorial. So for the person, they're feeling overwhelmingly feeling tired, very low energy levels, they're feeling that they need to slow down, general sense of sluggishness. Often they can feel quite breathless, and that gets harder as they're doing more exerting activities. Cognition affects cognition, concentration, normal activities, maybe watching the TV, reading a book, they're finding that really hard to hold their attention for any length of time. Obviously, we're all probably aware of kind of the chemo brain, chemo fog, but it is actually a more recognised condition now, titled cancer-related cognitive impairments, and there's a lot of work being done around that as well at the moment, as it becomes more and more recognised and not just an inevitable thing of treatment. Lots of people, their behaviour changes as they stop socialising, the social network reduces. If you're working, then you'll cut your hours down at work. And often it's because they actually anticipate feeling that fatigue, so they just won't do it anyway. And that, people feel very emotional, very low in mood, frustrated, isolated, and that, impacts massively on people's quality of life. And it also, impacts not just the individual, but their wider circle of family and friends as well. So I'm just going to give a little example of a case study rather than just reading. You feel free to read off the slide. So this was a lady who I met in an outpatient appointment, very, very independent, was looking after, she was in I think late 70s, looking after a great grandson for a couple of days, fiercely independent, very socially, like a little social butterfly, had a really wide social network, and that included a family. So she had her first treatment, and the fatigue hit her like a brick wall. And the problems that we discussed was that she really had not realised that, okay, somebody might have mentioned feeling a bit tired, but the overwhelming feeling of tiredness, and that was how she described it, it was just overwhelming and debilitating. She thought she was alone. She thought it was just her experience this fatigue, and everybody else is all okay. It's just me. There's something wrong. I'll just push through. So she was pushing herself very hard to continue with her normal activities of daily living. She was falling asleep during the daytime, which then impacted on her nighttime sleeping pattern. So she wasn't sleeping very well and just lying awake through the night. She stopped looking after a great grandson, which was a really valued occupation, just because she couldn't manage his needs. She stopped socialising and became isolated very, very quickly. Kept falling asleep in front of the television, couldn't read a book. And she felt very alone and isolated. Isolated from the family, felt the family perhaps didn't understand what was happening. She couldn't complete the valued role of the childcare. That also then she felt guilty because that put an additional impact on the family, because they had to look for further childcare, which was at a cost to them. And she was very isolated from her friendship group. And psychologically, this lady was then worrying that, the treatment wasn't working, the cancer was progressing. She was very frustrated, feeling very low in mood, and everything was, quality of life. She didn't feel she had any quality of life. And if this was how she felt after one cycle, she was potentially thinking, I can't cope with any of the other cycles. So from that case study, is there anything that could have been done, or is there anything that we can do for cancer-related fatigue? Is that yes, we can, but there's no magic pill. It's not going to take it away. It needs a complex, multimodal approach, and it's more about education and self-management. So one of the main things I think as a clinician is that we have to just ask the person about the fatigue, listen to them, validate their feelings. It's their lived experience. Everybody's an individual. They'll experience the fatigue very, very different to the next person. We need to find out what their understanding of cancer-related fatigue, were they given any information at all, if they're experiencing it sort of midway through their cycles. And I think it's really important to empathise and understand that the impact is having that on them as an individual. We need to ask if they've got any support, if they've got any family or friends that can help if need be. What are their current coping strategies? Are they healthy coping strategies? Are they not? And I think one of the key things is, what impact is it having on that individual? What effect is it having on their quality of life? And is there anything that we can support with from that? So as I said before, education is key. And a lot of the education around fatigue management is about self-management techniques, and trying to give those individuals the control back in their lives that they feel that they've lost. So even basic information can help and provide that difference to individuals. It's important for the individuals to actually recognise that the symptoms are related to the disease and their treatment, and it's a combination of how their body's reacting to those different things. I think it's really important. One of the most important things I think is to say that they're not alone, because they feel very alone. A lot of the time that people will say to me, I thought it was just me. I didn't realise that it can be like this for everybody. They have to have no idea of how prevalent it is. And as I say, everybody's individual, so they'll experience it at different levels at different times in their treatment journey. It can be fairly transient, depending on where the cancer is and the treatment regime that they're having. It may be that the first cycle, it hits them like a brick wall. They then have a bit of a rest between the cycles and it goes again. and maybe the first cycle is always the worst. But again, some people can experience fatigue months and even, unfortunately, years after the treatment has finished. And I think it's really important that we as clinicians need to let them know that there are things that we can help with mitigating, and that we can support them with those things. So one of the main things that we would teach is to try and avoid the boom and bust. So every task that we undertake, from getting out of bed in the morning to undressing for bed at night time, requires energy. And it's a pattern of supply and demand. And if your energy supply is low or disrupted and activity levels are high relative to how you're feeling, the body cannot meet those demands. So what happens a lot of the time is sometimes people wake up and they'll think, oh gosh, I feel really good. Today's a good day. So they will push really hard and they'll try and achieve everything that they want to do in that day and more. And then it acts as a boom and bust. So then they've done everything that day. The following day, they can't move. And if that individual was aware of that kind of cycle, the boom and bust, they might have actually done something about those activities and spaced them out a little bit. Some people are prepared to take that risk if they know that this is normal, that they've got a really important thing to do one particular day. It's going to take them all day. If they know that the following day or the following couple of days they're going to really struggle, then sometimes it's worth doing that activity because it's so important to them. But it's about educating that then rest beforehand, rest after, to achieve that really important activity or number of activities in a day. And that kind of gives them the control. They think, well, they can accept that they're going to feel awful for a couple of days. They need to kind of encourage them to have, speak to family, let them know. I think that's one of the things that a lot of people struggle with, is that people think you look okay, despite what you're feeling. And family will say, well, you look okay, so what's the problem? And again, it's that lack of understanding that just impacts on the mental health as well. And like I say, it's all about the self-management and the putting the energy in and using it slowly. So this slide on the green line is kind of a normal person like you or I. You wake up, hopefully, after a good night's sleep with 100% of energy. Throughout the day, your energy depletes in a normal way, so that by the end of the day, you're looking at maybe 10 o'clock, 11 o'clock at night. That's when your energy is gone. You go back to bed. The red line is the person with the cancer-related fatigue. So they wake up with just 50% of their energy. It depletes very, very quickly. And by 3 o'clock, they've got nothing left to give. And if you can imagine the impact of those few short hours in a day, then that's it. You can't do anything else. The impact on that person's quality of life is huge. And they're trying to cope with everything over a very, very short space of time. The other side of the graph is how we would like people with cancer-related fatigue to kind of work. So you wake up, with 50% of your energy. You do an activity that depletes your energy. You have a rest. Your energy comes back up, but not to the levels that you had before when you woke up. Rest, and then you can go again. And it's a more of a gradual decline, resting between activities, gradual decline, and then it extends your day because you've managed to manage that fatigue a little bit better. And it enables them to do more. One of the other common things that we talk about for cancer-related fatigue is the 3 Ps. So it's really important to plan, prioritise and pace your activities. So when we say plan, it might be that you've got numerous things to do in a week. Space those numerous things out over the week if you can, but plan your activities, but also plan your rest, because that's really, really important. So there needs to be set, sort of times in the day that you can sit down, have a sleep if you need to, really kind of take the weight off, and then go again with one of your activities. Prioritise. And again, it's what's important to that individual. It may be that, they've got something that they want to do with the family on a Friday. that's fine. You earmark that activity, and the run up to that activity, you prompt them to rest, and then afterwards you prompt them to rest as well. And it's about having the priority, doing meaningful activities. That's where your quality of life will come from. And maybe delay any activities that are not quite so important. Or this is the hard one that people say they can't do, is ask somebody else to do it. That's we feel as individuals we're obliged to do everything. We're not. Use your support network if you can, and pace your activities. So that's about not rushing, having the rests, and there's lots and lots of information online about the 3Ps. Some of the other main things that we look at is nutrition. I'm not going to go into that because we've got a dietitian speaking after myself. And the same goes with medication. Lots of medication cause fatigue, and that will be looked at more by Sam shortly. Exercise, we always, when people report it was always like, oh, rest is best. It's not, unfortunately. We encourage people to exercise, even if it's just walking around the house a little bit more. It is proved that exercise and activities do help with fatigue. The worst thing that people can do is to sit down and do nothing. Even if you feel like it, it's the worst thing possible. And then sleep hygiene is a big thing. It helps with the fatigue. You need that routine. You need your environment to be settled. There's lots of things that you can do online, lots of apps for mindfulness, lots of relaxation, things like reducing caffeine, not having heavy meals beforehand, and having a very regular routine if you can, because it does all help with the fatigue-related management. So just a few top tips with regards to managing fatigue is acknowledge the impact on individuals, and particularly psychologically, because quality of life is incredibly important. And if you've not got that, what's the point? Let patients and families know that the impact of fatigue, and it's very, very common. How it affects them is unique, but it's all about education, self-management. Information is key. Try and avoid the boom and bust. That's, important. Sometimes you can't avoid it, but managing that would be better. Activities need to be meaningful and purposeful, and enjoy the activities. Adapt your activities rather to reduce the amount of energy that is needed, and that to have small achievable goals to make everything kind of seem like things are a bit more normal. Now I've put this on. This is a document that's been, we had it. It's just been recently republished by the Royal College of Occupational Therapists, and it's an A4 document that's downloadable by anybody. It can be health professionals. It can be general public. They can go onto the Royal College of OT website and download it. And it's a really, really good basic tool to be able to use. Everything that I've spoken about is in this leaflet, and also at the back of it, there's lots and lots and lots of different ways that you can adapt activities. So even if, as an individual, yes, I know a lot of the time occupational therapists are seen as looking at fatigue all the time, but it's everybody's job to be looking at fatigue and trying to help that patient manage it. But it is a really good, useful tool, and I would encourage people to have a look and download it. And if patients are really struggling it, give them a copy or tell them, that they can get a copy online. And that's it. That's it from me. Thank you.
Thank you very much, Helen, for a very useful talk. I know you've done a lot of work into fatigue management, and it's useful to hear about the non-pharmacological options, because sometimes as clinicians, we do feel quite helpless when dealing with patients with fatigue, and there's almost a tendency to dish out more medications. So thank you very much on that. Please feel free to add any questions for the audience. The audience, feel free to add any questions for Helen, rather, and we'll take this at the end. So thank you very much, Helen. So moving on, talking about medications. Next up, we've got Sam Pan, who is a pharmacist at the Christie's NHS Foundation Trust. She's going to talk about medication review in older adults with cancer. Thank you, Sam.
Thanks, Cassandra. So, like Cassandra said, I'm a specialist pharmacist and I also act as a non-medical prescriber in the senior adult oncology team at the Christie. So first of all, I just thought I'd cover what polypharmacy is. So polypharmacy just means many medications. Usually in the literature, it's defined as taking 5 or more medicines, and it can not necessarily be a bad thing. It can be rational and required. So it's really important to distinguish between appropriate from inappropriate polypharmacy. Older people by nature are more likely to have polypharmacy because as you grow through your life, you collect more morbidities. And older people, lots of these older people with lots of medicines are excluded from clinical trials and practice guidance, so it can be quite difficult to make treatment decisions. So in my clinic, the way I reduce polypharmacy is doing a structured medication review. So these are holistic, personalised, and review of all the medicines a patient is taking. So we use the principles of shared decision making when making decisions about starting or stopping medicines. So we look at all the medicines they're taking, including all of the over-the-counter treatments, and then based on the clinician's experience or the clinical evidence, but also the patient's experience and circumstances and preferences, will agree to continue a treatment, discontinue a treatment, or start something new. So in order to have shared decision making, we need to give all of the appropriate information to patients so they can make informed decisions about which medicines they want to take. And at the end of the consultation, we need to record a clear plan. So all of the communication about any changes made gets shared between all clinicians involved in that patient's care. And I just thought I'd flag there's a really useful website called MedStopper where you can put all medicines in and all the indications in, and it might suggest, according to the guidelines, which ones maybe we could think about stopping. So it's worth looking up in your free time. Next, I'm going to talk about anticholinergic burden. So anticholinergic drugs are drugs which block the action of acetylcholine, and they usually have lots of side effects, things like blurred vision, dry mouth, constipation. But when we give these medications to people over the age of 65, they can also cause things like confusion, dizziness, and falls. And it's been shown this can increase patient mortality. So again, there's a really good website which I like to use in my practice called the ACB calculator, where you can put all the medications that the patient's taken in and it'll calculate a score for you. So any score above 3 is associated with an increased cognitive impairment and mortality. So you can see here, all drugs have got a score of 1 to 3. So you can see this patient who I've done this for is on amitriptyline, and amitriptyline is a high anticholinergic burden drug and automatically has a score of 3. So anyone on amitriptyline is already high risk. They're also taking this alongside chlorphenamine, which I just thought is important to think about because a lot of chemotherapy regimens use chlorphenamine as a pre-medication, and this could cause falls and confusion in older adults. And then codeine has got a score of 1. So in total, this patient has got a score of 7. And because that's above 3, that's a high risk for falls and mortality and confusion. And I just thought I'd also mention these start-stop criteria. So that's evidence-based criteria used to review medication regimens in older adults. So the STOP refers to screening tool of older persons potentially inappropriate prescriptions. So that's aiming to stop any medicines which aren't appropriate anymore. And START is a screening tool to alert right treatment. So that's to prevent any omissions of indicated treatment for patients. And this is actually included in the British National Formulary. So you can see this monograph for diazepam. It's got a section for prescribing in the elderly, and it gives all the situations where you might want to stop prescribing diazepam in the elderly. So, for example, one of them is if they're having lots of falls, it might be appropriate to stop diazepam because this could be contributing. So in terms of falls risk, falls, as we know, are multifactorial but could be related to medications. So I thought I'd include some easy wins when reviewing medication if a patient is at risk of having falls. So one thing we like to do in our clinic is lying and standing blood pressures. So if anyone's on any antihypertensive medication, they could have hypertension or a postural drop, which could contribute to falls. So postural drop is defined as a drop of 20 systolic or 10 diastolic in the blood pressure. And if this happens, then we probably have to review the antihypertensive medications. Next, we try and avoid sleeping tablets. So if someone's having problems sleeping, we would always try sleep hygiene first. Then we could look at any newly started medication. So if they've had a sudden increase in falls, check any newly started medication and their side effects listed. Look out for things like dizziness, drowsiness, because those could all contribute to falls. And then check pain control. So if patient's not having any pain, but they're on pain medication, and they're not requiring any breakthrough pain relief, could any of their long-standing painkillers be stepped down? Of course, there's exceptions to any rules. So when I am reviewing patients for falls, in terms of Parkinson's medication, a lot of them list that orthostatic hypertension is a side effect, but then Parkinson's disease also can cause orthostatic hypertension and falls. So it's really difficult, complex balance between medication and the disease. So if I had someone who had Parkinson's who was constantly falling, and I felt that the medication might need to be reviewed, I'd always refer them back to their specialist. Again, symptomatic hypertension in systolic cardiac failure, ACE inhibitors and beta blockers actually have a survival benefit, so we should try and maintain them whenever possible. So first line, NICE would recommend stopping other medicines which could be causing hypertension, things like nitrates, calcium channel blockers. And if they've got no congestion, we could think about reducing diuretics. But if the problem persists again, I'd involve a specialist. So one thing to think about is the mortality risk from having a fall at age 85 is about 1% per fall. So we use that figure to try and really balance the risk and benefit of any treatment that we might stop for falls. But again, it's sometimes quite difficult to quantify, so that's just a rough guide that we use. One of the problems if someone's taking lots of medication is there is an increased risk of having drug interactions. So drug interactions occur when the effect of one drug is altered by co-administration of another drug, food or herbal product. So there's lots of free sources if you don't have access to a pharmacist where you can check medication interactions, things like the BNF, the Electronic Medicines Compendium. So you can see there of the bottom picture is of a summary product characteristics where there's a section for interactions. And also there's a really helpful online resource made by the University of Liverpool called the Cancer Drug Interaction Checker. So I like to check all of those, especially if we're starting anything new, check if it interacts with any of their existing medications. And one of the final things I'm going to talk about is thinking about patient compliance. So non-adherence can be intentional, where a patient is choosing not to take a medication for whatever reason, or it could be unintentional. So they might be forgetting or finding it difficult to manage taking the medicines. So if someone's not taking the medicines, we really need to explore the reasons why. Could it be that they need a bit more education or encouragement? Or if they've really decided they don't want to take it, then it's probably best that we advise that we stop dispensing that medication to avoid wastage. And then if they're forgetting to take their medicines, there's some things that we could try. So there are medication compliance aids like dose set boxes, which can be used to support people who may find taking medication difficult. But there's very little evidence to say whether these devices actually improve compliance, safety, satisfaction, or the convenience of taking medications. They're very difficult and costly to make up in pharmacies. And a lot of commonly prescribed medicines aren't actually suitable for storage in a dosette box because they can break down or expire. They need to be stored in their original packaging. So some things we might like to try first line instead of jumping straight to the dosette box is things like alarms, medication reminder charts, or other prompts like that, or seeing if anyone from their family might be able to help support them with the medicines taking. So that was it. Thank you.
Thank you very much, Sam. That's again very useful tips, and it's really nice to see the role of pharmacists with regards to kind of medication review, which often can take quite a lot of time, and sometimes patients don't even know what they're taking, which makes it even more complicated. So thank you very much for that. So next up, we've got Laura Newman, who is our dietitian. She is going to talk to us about nutritional support for older adults with cancer.
Sorry. Yeah, can everyone hear me now?
Yes.
Are we good? Okay, I did click it, but I don't think it's stuck. Okay, so first of all, I just want to draw your attention to some guidance that is available on the British Dietetic Association website that came out the tail end of last year. So it's a healthy eating resource for older adults, but it gives a really good overview of what the current evidence base is for nutritional recommendations for the older adult. So it's got things on there like enjoying and eating and drinking, maintaining a healthy weight, but not necessarily worrying about weight loss if you're on the larger side. It encourages activity, which we've already heard about, sort of the benefits of activity and fatigue. And it recommends certain nutrients, so things like vitamin D, calcium, folic acid, B12, protein are really important in that population, so more so than younger adults. It was commissioned by a university, so they've looked at what is the current evidence base and put together this resource. So some of the recommendations on there, like having 1,600 mils and 2,000 mils of hydration for women and men, that is mirrored from the SPEN guidelines for the older adult as well. So it's a really good resource, and I guess it's looking at what we're trying to encourage people to be working towards, so that if they aren't doing so great with their nutrition, ideally you want them to get to here. This is kind of like, and some people will be nearer there than others. So I just thought I'd let you know about that resource, and it's available online on the website, so anyone can kind of access it and print it out, or whatever's easiest. So just to draw your attention to a few relevant guidelines around nutrition. SPEN, which is the European Society for Clinical Nutrition and Metabolism, have a couple of different relevant guidelines. So because our patients are kind of more than one thing, there are two guidelines that this patient population will be kind of relevant within. So you've got the Clinical Nutrition and Hydration in Geriatrics Practical Guideline. So that's really good at looking at kind of the practical side of trying to kind of meet the older adults' nutrition. So it runs through what their actual requirements are, but it also has lots of principles of nutritional care and kind of like what you should be looking at in order to kind of meet an older adult's needs. And it encourages things like multimodal and multidisciplinary team intervention in supporting someone to have adequate nutritional intake. And then you've also got the recommendations for clinical nutrition in cancer. So it's the fact that we've got two massive big guidelines for these two different things is kind of like key in showing there's some vulnerabilities there, and there's no guideline that sums up the two together. You've kind of got to look at both to draw out the relevant information from those. And then I've got the NICE guidelines that hopefully most people have heard of for oral nutrition support and enteral tube feeding parenteral nutrition. So they're kind of like the UK clinical guidelines that it's probably worth familiarising yourself if you have got a nutritional issue and you're not quite sure what to do. And then I've given you 3 different screening tools that are good. So the MNA is the mini nutritional assessment, and that's a good tool because it's been validated, and it's been validated in the older adult population. So it's very good at drawing out nutritional risk in that population. MUST is really well known. A lot of people use it, so it's valuable in that it's a commonly used tool. But I think there's some weaknesses there in terms of getting symptoms for cancer patients. I think it doesn't always pick up on those sorts of difficulties that could cause someone to become malnourished really quickly. It might not pick them up early enough. And then there's the PGSGA, which is a subjective global assessment screening. And so it does have a bit of different things like symptoms and looking at muscle and other things. So it's just to give you an idea that these are really good guidelines. I'm not going to go into them any more detail today, but if you've not heard of them or you want to know more, I would definitely suggest looking them up. So there's 3 different things that might be happening when somebody is struggling nutritionally in this setting. So you've got your disease-related malnutrition. You've also got sarcopenia, where we're looking at specifically losses when it comes to muscle mass. So obviously with frailty, that's going to be kind of like a real big risk factor there. And then you've got cachexia, where we see losses that are kind of very much involuntary and difficult to overcome. So sometimes we will treat the malnutrition, but that treatment will be limited in its impact, and there may be higher kind of stress factors and things that are happening that cause cachexia. So it's just to give you an idea of there's a bit of crossover between all of those 3 things. I think this is quite a nice diagram explaining the 3. But also obesity is obviously on the rise. So it can really mask both malnutrition and sarcopenia. And I think it's really easy to be like, oh, well, that person's big, so they don't have any worries nutritionally. I think it's very easy as clinicians to not realise the underlying risk and loss of muscle mass alongside fat mass loss that can happen there. So it's just to draw your attention to that. And I've also got on the bottom a link there about, so there's a lovely pathway online called the Malnutrition Pathway. And it's got a whole section on cancer resources, and it has different profession-specific resources on there. So again, if you're not sure what you're doing and you're new to malnutrition, the Malnutrition Pathway has got lots of lovely resources on there, and I think I probably got it on more than one slide. But like, just to try and keep things a little bit more simple and not like clinical guidelines, what do we do to identify malnutrition and other elements thereof? Looking out for weight loss. Again, like ideally more than 2 numbers to look at, because like different scales might not have been calibrated. People might have been wearing their shoes. They might have had a full leg bag on. There's lots of reasons why weight isn't always the be all and end all in terms of looking at someone's overall nutritional picture. But trying to see that, if you can see that, yeah, they've definitely been weighed regularly, we can see that trend, we're happy that's a definite trend, like we want to look out for that weight loss. But also muscle loss. So again, whether or not it's doing things like certain tools that look at whether or not people can stand up as quickly, how many times they can stand up in 5 minutes, there's different things around that look at muscle loss and look at hand grip strength could be done. But getting an idea of how somebody's ability and physical activity has changed can give us an idea of if strength is changing as well, and we can look out for sarcopenia that way. Appetite loss, if they're not eating as much, they're bound to be at nutritional risk. And if there's reduced intakes, losses of some sort are likely. Even if it doesn't cause weight loss, potential other losses are going to be there. And even, just meeting micronutrient intake needs will be more tricky as well. So symptoms that increase risk or reduce intake, there's lots of common symptoms that I'm going to go through in a little minute in the cancer setting. Obviously, we've gone into fatigue in good detail, but even if they're not clinically fatigued, but they are more tired or have altered mood, that is likely to have an impact on how well someone is eating. Even if they might eat a bit better depending on what's happening. Everyone is individual when it comes to nutrition. Also looking out for things like wound healing. Like older adults are more vulnerable to developing things like pressure sores, and their requirements for things like protein are going to be higher in that instance, and they may have long-term conditions, things like COPD, that increase their nutritional requirements. So I think having an understanding of the sort of the stress and kind of any healing the body's needing to do might make us think, they're going to be nutritionally vulnerable. Is there anything else going on? And again, Helen gave us some really good ideas around different social and physical barriers around kind of general day-to-day life and getting your meals in as part of that. So there's going to be different social and physical barriers to eating well and all. Okay.
Yeah, we can hear you.
Okay, lovely. Am I back? Lovely. All right. So in terms of kind of nutrition impact symptoms, I'm starting off with the ones that affect the mouth, chewing and swallowing, because that's like pretty impactful. So poor dentition. People, if they're losing weight, they might end up so that their dentures don't fit anymore. So then they're really struggling. Like that kind of makes it even trickier, that they weren't eating well in the first place, and now their dentures don't fit, and so they're only able to eat soft food. Finding out about what's happening around dentition is quite important, and looking out for symptoms like mucositis, esophagitis, oral thrush, mouth ulcers. They can all make it tricky, and there's different medications that somebody might be able to be on to help with those. It may be that we might need to do more nutritionally for a little while we overcome those symptoms if they're associated with treatment. And then there's things like dysphagia, where obviously like linking in with the rest of the multidisciplinary team, so speech and language therapists and things would be really good. So we know what's easiest and what might go in kind of better in terms of like dysphagia and swallowing problems, and other things like just being short of breath. That can really make, if it's laboured to breathe, then getting food in between that can be tricky. So obviously I can't see any of you, and so doing an interactive eating exercise is going to be impossible, but I would recommend taking a bit of time to think about what it's actually like to go through some of these symptoms, because it's really easy for us, somebody who's never been through radiochemotherapy and has never been old, to say, oh, go and try this. But like, we don't know what it's like. So like, take a little minute to think a bit more about what it's like. That's what I'm recommending here. So the idea is you get a sweet or a piece of fruit and you try eating it with your mouth open, and then you do that again, but you try it with your mouth closed, but without moving your tongue. And hopefully this will give you some insight into how difficult that is. So it'll model how it might feel if you're not able to get good lip seal. It'll model what a dry and ulcerated sore mouth might be a little bit like. It's nothing like that, but it gives you an idea of some of the difficulties you're experiencing in just trying to do something a bit weird that you don't normally do with your food. And if you do it with your colleagues, you can kind of try and say a bit about how it made you feel and what that psychological and social impact would be if that's how eating was for you, day to day, meal to meal, snack to snack. And then you might have a better idea about how tricky being like, just eat more little and often and have a bit of food every hour or two is actually going to be. So, that's my recommendation, to try and get a bit of insight. Other things that it's worth trying to find out about when you're looking at symptoms that we want to try and improve. Appetite and early satiety are really, really common. A lot of people might just get them as part of aging anyway. So they might say, well, I've not eaten great for years now, but I'm not doing as much, so it's all fine. And then you've got things like nausea, sickness, taste changes. Different problems with the bowels are going to impact in different ways, but being bloated and uncomfortable isn't going to help you eat nicely. I've already mentioned about wound healing, but things like pain, massive impact on how well you might eat. We know about fatigue and sort of physical function. I think even just sometimes people getting their pain under better control, improving their physical function, and that can, without me doing anything, make nutrition be better. Like, I don't necessarily have to do anything from a dietetic point of view. Somebody just improving a couple of factors that have been making a bit of a change, they might say, oh, I took on board all your advice, but I've not actually done any of it because I'm just back to eating normal now because these two things have been taken care of. And that's great. I'd much rather have my job done for me by the patient wanting to do what they want to do and it working for them now because their factors, like their nutrition impact symptoms, have gone. So it's important to understand overall social factors and mental health and what's going on there as well, to just see if there's changes that could be made to improve things. And a patient of mine in the past used to be somebody that I was trying to tell off in a renal setting for always drinking more than he needed and always having a high phosphate. But as he got older and other challenges crept in, social factors were actually quite protective for him. So he was able to have his granddaughter go in at breakfast time and like cheville along to just eat because he was just struggling and losing weight. And she'd go in every day before school and get him eating. So there's different protective factors that people have. And sometimes it's getting in contact with people and going, I'm a bit worried about your dad or whoever. Is there anything we can do at a family level to support? So food first principles. So this is about trying to come up with a nutrition plan that isn't just prescribing 14 Fortisips. So it's looking at the symptom control and that making that one difference can, like, no longer eating alone or managing the pain can just absolutely have a massive impact on how well someone is eating. But also trying to go for a little and often approach. But as I say, different people are going to have different baselines, and it's important to try and look at what's manageable. So trying to go for snacks or small meals or nourishing drinks every few hours, but trying to start with one or two things so that they won't become overfaced, that they might feel is actually quite easy to do. Overfacing is also a really difficult problem. So I think people's loved ones will be like, I'm so worried they're not eating. I'm putting this massive, lovely dinner in front of them and they're not having any of it. And I think if you're not feeling good for whatever reason, you're not going to manage much to eat if there's this big plate of food in front of you. If you're a bit nauseous, it smells a lot, you're not going to want it. If you get full up really quickly, you're going to be like, that's never happening. A little portion, something that's more manageable, can psychologically be so much easier. So having a really little portion on a smaller plate that's presented nicely, or having things they can pick at and have small bits and have a bit of a picnic tea or sort of finger foods available. They might have a few different bits, and that might mean there's a bit more going in. That, like, the difference is 2 mouthfuls from a big portion becomes a good half of a smaller portion, and that is going to be loads more nutrition. And then fortification. I talk about food fortification a lot in my line of work, but what do I mean by that? So I don't mean building a castle, but I thought that was a good little picture for it, just to make people think about it. So it's looking at what are you already doing? So what's your foundation? And can you optimize that nutritionally in some way? So that might be saying at the moment they're always having a glass of milk at bedtime, and they usually have milk in their breakfast. So what I'm going to suggest is they start adding skimmed milk powder to that milk. And so I know that they are always going to manage a pint of milk a day, and I'm going to say aim for a pint, because I'm trying to get a little bit more, but I'm fortifying that with skimmed milk powder. So they're not having to manage too much more volume, but what volume they are managing has more nourishment in it. So it's looking at little ways of doing that. So my next few slides, I'm going to do a bit of that, hopefully, but I'm not there anymore. I am. Okay. Did I skip ahead one? Sorry. It paused for me, which was confusing. And I've skipped 3. Okay, we're good again. So this is just a lovely list of what nutrient dense fortifiers. So nutrient dense, what do I mean by that? So basically anything that gives you lots of nutrients. So I've got some nice pictures on here, including like a plant that's growing. So anything that grows to a plant, or could grow into a baby animal, or that feeds a baby animal, it's going to have a good amount of lots of different nutrition. Stuff that kind of gives life is going to be packed full of nutrition. So things like your nuts and nut butters, your milks, your milk powders, yogurts, cheese, things like chickpea and pea flours and eggs, all really good products at getting in nutrients. So trying to use nutrient-dense fortifiers is really important in the older adult, because they're more likely to not be eating enough of everything. So kind of getting all of the nutrients they need is really important. And that's kind of a recipe of how to make fortified milk. But like, I'm always like, I think you need to give people flexibility there. So I give an idea that it would be good to put that amount in that amount, but like different people are going to tolerate different amounts. So I think trying to be flexible with your approach is really important as well. So if someone's like, I can put a teaspoon in and that works for me, that's still better than nothing. So, you know, we don't have to be completely prescriptive about what we do. Nutrient dense snacks. So I've got things like cheese and crackers, custards, yogurt, handful of nuts, sometimes just having a bowl of nuts on the side. Somebody who's like forgets about eating, they might then help themselves to that throughout the day and get them eaten. Like things that you kind of help yourself to that are nutritious are really good to have about the place. And then if eating is just a bit tricky, then looking at nourishing drinks. So you've got things like milks, obviously a really good go-to, but not everyone likes milk. So if you can't get milky drinks in, and sometimes people don't like milk, but they do like coffee or they do like hot chocolate. So you might be able to get a milky coffee.
Okay, yeah, you're back.
All right, I'm back. Sorry, it's the same room as everyone else, and yet this keeps happening. So we're on smoothies next. So you can put milk in smoothies and yogurt, but if you just don't like those sorts of things, you can make them with different fruits and vegetables and juices instead. And then obviously you can throw some different nuts and seeds and things, depending on kind of like how you like it. But I think that's like I've definitely seen family members coming into their elderly relative and bringing their homemade amazing smoothie, and I'm just like, I think you've already got this, and backing away. So having those homemade products can really be very, very valuable. And similarly, you can do stuff with soups. So if you can use homemade soups, but cream of or big soups are going to have more nutrients in than, say, like a vegetable soup that's mainly just veg but hasn't got things like potatoes or lentils in. So I think trying to have things like beans, pulses, lentils, cheese, meat, adding a little bit of creme fraiche, a little sprinkle of grated cheese can just make the difference when it comes to soup, because some people get on really well with soup and they eat it more easily and they enjoy that savoury flavour. So it's looking at adapting these things to make them more nourishing as much as you can. So in terms of kind of barriers to change, again, with the kind of what Helen was saying, sometimes there's an acceptance and a normalization of certain things that happen as you age. And I think weight and appetite loss and frailty are some of the things that people are just like, well, it's because of my age or it's because of my cancer. So it can be really difficult to engage people in wanting to prevent further losses or changes when they're accepting that this is just normal and just part of them, and what do they need to worry about. So kind of that reduction in appetite alongside a reduction in activity, they can be like, well, that's balanced. I don't see what the problem is. And like foods are no longer managed as part of like a generally reduced intake pattern, and that can be really individual. So I think there's barriers there to what people are happy with and happy to kind of let happen. And sometimes it's finding a way to overcome that barrier that can be quite tricky. Sometimes people care more about things that you tell them about, like, well, you know, that wound that's taking ages to heal? Well, that's because you're not getting enough nutrition. You know, like you can't do as much now. That's because you're not getting enough nutrition. Sometimes people care way more about that than the fact that they've lost weight. They don't care about the weight loss. That's not something that concerns them. But sometimes getting into like, well, what actually does concern you, and when that is nutrition related as well, can sometimes get over these barriers. And also, like, just kind of a word of warning that people can be super vague and massively underreport or overreport what they're actually eating. And our perceptions can make a real impact on what we think as well. So we might be told, oh yeah, I've got a really good appetite, my diet's really good, I'm eating little and often. And I've definitely heard people tell me that, and I'm like, oh great, it sounds like they're going to have a really good foundation, but they're actually just eating 3 really small meals now, but they're not having any snacks, no nourishing drinks. And so it sounds better than it really is. And then they might say they're having a balanced diet, and that they're having just toast and jam and soup and bread. But the main meal probably is balanced, because most people will eat a balanced tea, say, but a lot of people will just have carbs only for the other 2 meals. And like we're looking at trying to get a balanced diet that has definitely protein in as well as carbs, and ideally some other nutrients, but the protein especially is really important. And different people's ideas of portions. I've definitely had a guy who was putting on weight. I was like, I don't know why I'm putting on weight. And it's like, right, how many slices of toast? 7. But he used to have 10. And now he's reduced it to 5. And he's like, well, so that's pretty good, right? And it's like, well, yeah, it is. But we have different ideas of what a normal amount of food is, I think, from our own experiences and kind of like how we function. And you might have somebody who's saying, oh, well, you know, I'm having less, but they're having half of what they used to have. And I think that's where I always start to worry more, is when you kind of drill down a bit and try and find out how they actually are eating. And if they're having half of what they used to have, that's pretty bad. Nutrition wise, that's really going to have a big impact. And a lot of the nutritional screening tools will kind of look at that kind of cutoff. So this is just a quick overview of some possible changes. So if someone were having sort of breakfast and they were having sometimes porridge but sometimes nothing, we could look at maybe having some fortified milk to drink if they're not having anything, or they could maybe add a teaspoon of skim milk powder into the porridge. The cup of coffee, maybe they could use fortified milk or just make it a milky coffee. And again, full fat milk obviously has more calories, but the extra is like just from added fat. So it's not more protein. So if someone doesn't like full fat milk, I won't tell them to have full fat milk, because I'd rather they have a good volume of semi-skimmed milk still. So I'd rather they have a pint of semi-skimmed milk than they have 2 mouthfuls of full fat milk. So, food fortification, like it's got to make sense. And then, lunch, they're only having toast, so adding some egg or baked beans or cheese would be really good. The apple, could we spread some nut butter on there? That's a favourite trick of mine, just because it worked really well with somebody recently. Or like if there's other fruit they like, they could have it fruit and yogurt. And then like the evening meal, if they're just having a sandwich, well, could they have both those fillings? Could they have a cheese and ham sandwich? Or could they manage a pudding or an extra snack? It really just depends on how difficult the situation is and how easy it might be to make these changes. But some changes are going to be more manageable than others. But I think talking through possible changes and then saying whether or not they might manage one is a really good kind of way of kind of setting a goal, so the patient can be like, right, okay, I hear what you're saying, I'm going to start having milk and I'm going to start trying that. But having a few different options is good to talk through, because then they can pick one or two that might be manageable. Or nutritional supplements. I've just kind of thrown in some comments. Are they even necessary? Arguably, the studies that show that they're really good are obviously been funded by people who want to sell their product. And they're really good because they have lots of nutrition in them. But obviously you can make that from food. And there's not studies to show that they're better than doing that from food. So my argument would be, if you can achieve it through food, that's always going to be better. And then, are they wasted? Absolutely, like loads everywhere. That's why prescribing dietitians exist, to try and get loads of people off of things that are just having 2 mouthfuls and then going in the bin. And are they reviewed appropriately? Not so much. And I think that's the difficulty. It's easy to get someone onto these products, but then it's really tricky to keep an eye on, are they continuing to be used appropriately? Are they building up in the corner in the bedroom, and is there 90 bottles of Fortisip sat there doing nothing now? Or did they all go down the drain? And are they worth the cost for the proportion taken? I think for some people they absolutely are. For some patients, they really add something in an easy way that works for them. But I think that's why it's really important to make sure that they are prescribed appropriately, and not just because that seems like an easier fix than giving them some nutritional advice. And I've definitely had people keep taking supplements when they absolutely don't need them anymore. And I've had to write to a GP and say, I recommend this stops because they are now a BMI of 25 and they will happily keep taking this product forever. And I've told them to stop and they are ignoring me, and I'm a registered dietitian. People will keep using something if it works for them and it's easy and they like it. Word of warning about the supplements. But there's some really good pathways. So the malnutrition pathway I mentioned before, this is their diagram of how to do supplements right. So I would say, make sure you're happy you've optimized their nutritional intake without supplements first, if possible. Are they at high risk of malnutrition rather than just at risk? Are they likely to be compliant? And will it impact on the intake of other things? So are they going to manage 2 Fortisip compacts a day? Great. But are they then going to not eat any of their meals or drinks anymore? So what was the point? It's balancing all of those books. And then there's lots of different ones. So you've got different styles. So you've got the ready-made milkshakes and the sachet ones. Sachet ones are cheaper. You've got juices and smoothies. You've got some savory soups and shots, desserts, and there's high protein, low fiber, low volume, fiber containing. And you've got different flavors. And it can be getting very boring having the same flavor all the time. So avoiding flavor fatigue is really good. But you can try them in different ways. You can chill them, you can freeze them, you can make ice cream with them, you can warm them up, you can dilute them. And most are able to kind of sip throughout the day for 24 hours. And you can take them in one go, you can take them in shots. But there's lots of different ones. There's companies with sample services as well, so you can try before you buy. And they've got recipes on there that like to show you how to use them. So this is the malnutrition pathway. Again, so I'm just sort of highlighting, they've got things like leaflets on fatigue, which again links into the leaflet we saw from Helen before. It's on there. And there's another one that's got loss of taste changes. And then on that leaflet about fatigue, there's some basic store cupboard ideas. There's a link on it for that as well. So it's just to show you, I'm not going to read through all of these things, but I'm just showing you some resources. And then in terms of taste changes, because I think it's a really big one post-COVID and all, there's more and more of it happening anyway without the cancer and the treatment. So there's the Ryan Riley recipe booklet on the World Cancer Research Fund website, and you can order a hard copy if you put your email address into that as well. So I encourage patients to do that. And then sometimes smell is affected and that can impact taste. And there's a really good charity called Absent that have smell training resources. And then there are things like meal delivery services. So that's just an example of 3 of the different ones out there and some of the good things about them that might help. And then there's other written information about nutritional things you can get from the British Dietetic Association. So as well as the older adult guidance I mentioned, there's food fact sheets on like pretty much anything there could be a food fact sheet on, but they're going to be evidence-based, written by a dietitian. So if you haven't got a dietitian you can ring in your back pocket, you can find some information on the BDA website as well. And that's it.
Thank you very much, Laura, for taking us through a very big topic. Sorry we had to rush you at the end, but lots of very useful tip for me as well. So next we've got Ada Ward, who is an occupational therapist. She's going to talk to us about community support for older adults with cancer. Over to you, Ada.
Thanks, Cassandra. So I'm going to give a brief overview of the community support available. I'm not going to touch on what the support available through the Macmillan Societies or groups because everybody knows about them and they do a fantastic job. So to start our journey, we're going to look at what support your older person may have in place if they've recently come out of hospital. So they would have been discharged on a discharge to assess pathway, commonly known as D2A. And this is purely a hospital discharge pathway. So pathway 0 is known as no needs or no complex needs. And this is generally for people who just go straight back home and have no contact from any professionals, volunteers, etc. Pathway 1 is, have I dropped out? Pathway 1 involves reablement, social services, volunteers and home warmers. This is very common and the probably most common pathway a lot of people come home from hospital on. This is a pathway where you get your carers on. Now, these carers are not a permanent arrangement or the input from the volunteers, etc. would not be permanent. There will be up to potentially 6 weeks of input. Recently, there has been some changes regarding what's been available, but just to be aware, it does fluctuate from area to area. Home warming service is available in some areas of Greater Manchester where a person pops out to the individual's home before they come home from hospital, pops the heating on and sometimes does a basic food shop. It basically comes down to it, if you don't ask for it, you don't get it. So it's always worth inquiring to see what's available. Pathway 2 is intermediate care, that is inpatient beds. So everywhere has generally got units. Stockport do it slightly different. They purchase beds in residential 24-hour care homes and then put their input into that. Now, the intermediate care has been just re-looked at. There was new framework guidelines introduced last year. So they are looking at trying to meet the demand because that's possibly one of the biggest challenges on these pathways. Pathway 3 is what is known as 24-hour care placements. They are interim, they are short term. This would not be the person's long-term residence and it can depend. It's mainly a period of recuperation for people who maybe have needed longer to recover. Manchester has got a team that will work with people on pathway 3s to get them to their preferred place of residence or where it's most appropriate for their needs. So that some people can go from pathway 3 to home. So nothing is definite on that. And I believe that Trafford have just started a team similar to this. The most important thing to be aware is that although all these pathways exist, demand and need is high, and you can't always guarantee what you get. For example, Trafford at the moment has got a limitation on pathway 1, and they're only having one visit, which is make safe and stabilise, and then one further visit because they cannot meet the demand. So do ask, but just be aware that it fluctuates from area to area, and it will depend on what's available in the community. So what are we entitled to, or what support can we get if your person's already in the community? Well, they're covered by the Community Care Act, which has been around for quite a long time now and probably needs updating. And this focuses on what the person needs. That's the whole emphasis on it. And this act has given the local GPs the ability to buy in their own services and choose what to purchase, but it also has an obligation on the local authorities to do a care and needs assessment. This covers home care, respite services, daycare, reablement and preventative services. Unfortunately, this is for everybody. So it's from cradle to grave, as they say, for all conditions. And if you think about what's happening in Birmingham's local council, which is on the news, that it does depend again on your local authority how they will respond to what you need or what they'll be able to offer. So Greater Manchester has got a massive variety. But it's again, this is really important where you can advocate for your patients using the information you've got today to say, actually, my person has got needs, and explain the reason why, because sometimes that can help them tick the boxes to get the computer to say yes. Not the way you want to do it, but it does. So what can you do if your person is at home, is in a bit of a pickle? Everywhere should have an urgent community response service. Now, this is run by the integrated care systems, and they can be known as rapid response, D2A, like crisis response. It changes names from borough to borough, but basically the principle is the same. It's to keep the person safe at home and to try and avoid a hospital admission. And it's really important that if you need this service, it is available 8 to 8, mainly 7 days a week in most areas. And you can access this, and you can access this as well via your GP. There is changes again locally about doing what we'd call welfare checks, etc. The police used to be able to just go and, if you're worried about somebody, do a welfare check. Again, because of resources, that has changed. But you can contact your GP and maybe say you're concerned about somebody, and the district nurses may or may not, again depending on their resources, be able to help you out. But if you do think that somebody's at high risk, or falls in particular, please make sure they've got pendant alarm or telehealth available to ensure that they get the support. Now, for your pendant alarms, you can get them inbuilt with fall sensors, continence sensors sometimes, and seizure sensors again. All of this depends on your local borough, but it's always worth asking, and do please ask. So what do our older adults look like in the community? This is a common perception of how they look like, but we have to be aware of compassionate aging. We can perceive that somebody is inherently needy or that they deserve help, but we have to be very aware about our language and our behaviour to ensure that we don't disempower or patronise people, because that can cause them to disengage. So it's really important that we are aware that everybody's a bit different. And on that note, as you can see from this slide, that we've got a wide variety of different people that come in all shapes and sizes, and they've got different beliefs and personalities. And just to make you aware, the lady just there on the picture beside the word like, she is 107. She is a UK resident, and she says she enjoys her cigarette there and her small tipple, I think, let's hope it's small, every day. So we just need to be aware everybody's different. But the one thing that is very prevalent within the older adults is loneliness. There is a stigma about loneliness for all age groups, but in particular with older people. Even if you directly ask them how you're feeling, they will probably underreport it. 2.9 million people over the age of 65 do not feel that they have anybody to turn to for support or help if they needed it, which is really quite a sad fact in today's society, considering we've got so much technology and way of getting in touch. Now, Age UK are running a campaign, which unfortunately is coming to the end, but it's well worth having a look at it. It's a campaign to end loneliness if you're interested in this. So it's there and it's very prevalent within our older adults. So what does loneliness look like? These pictures just depict that it can be somebody who's out and about and looks okay, going for the walks. It can be somebody in a group. It can be somebody who's got family around them. Loneliness is a feeling, and I think we often underestimate and don't talk about it. So it can be something that we need to be aware of. So we also need to see how we can help people. So we have got services like the Silver Line. This was originally established by Esther Ranson. It's been around for quite some time, and now it's run by Age UK to have it more stability in its long term. It is free, it is confidential. You can ring them day, night, anytime. A lot of the time when people experience loneliness, it can be very late at night or very early in the morning because they don't sleep as much, or they've got some like dead time when they're going for their supper, and you can phone up and have a little chat and nobody will ask any questions. It's just about friendship and companionship, and the number is at the bottom there. So it is a really good resource to advocate for people. Another resource is MindEd. This is a fantastic website that's available. It has been set up by NHS England, and all of the materials on this website have been wrote by clinicians. So as you can see there in the little boxes, if you clicked on I'm lonely, that would go into what loneliness is. It would explain what the cycle of loneliness is. And I have to give you, I would definitely say check out the story. It runs a patient's story about the impact of loneliness on their life. Pre-warned, it's a bit of a tearjerker, but it is very impactful in understanding that it's not something that we should underestimate. We also need to be aware that we shouldn't confuse loneliness with depression, but they're both important things to address. If you have got 3 long-term conditions, you are more prevalent to have a depression, but both loneliness and depression can be addressed, can be reversed, and that's why we're very keen for everybody to get involved and to be aware of what these resources are. These resources have also been written for clinicians to use, but also for the individual themselves and their family. How many times have you have a conversation and you just go, they're just grumpy, or dad's just grumpy, or mum's just grumpy, or he's always like that when I married him, whatever, blah, blah, blah. So this resource, you can say, well, let's look on this website together, or get a family member to look on it, and it actually explains it in terms that they can be engaged with. So do have a look. It's really good. Again, because we're talking about the Greater Manchester area, one of the consistent groups around and volunteers is Age UK. They do vary from borough to borough what they do, but they do befriending, confidence walks, as you can see, luncheon clubs. They also can give guidance sometimes on DIY and handyman. They can have people who have linked in with them. So it's important that the practical support as well, and they're kind of better addressing social frailty. They have more time and more resources than you will get from social services, because again, just think of Birmingham Council. Are they going to be interested in somebody's getting their light bulb changed when they have got, I don't know how millions in debt? And I think Manchester is the same, but just not as bad as Birmingham. So, and finally, when other community supports we're looking at, people's different religious and spiritual beliefs have also been a good place to access support. If it's important to them, we need to value that. And if you touch out and reach into whatever they're linked in with, you will find that there potentially is help available. People's ethnic heritage as well. In Manchester, you've got the Afro-Caribbean Society, you've got the Irish Society. There is numerous societies throughout the whole of Greater Manchester that will, if you give them a little Google, then you can contact them, and they are really good sometimes at providing that different level of personalized care. Sometimes it's food that you can't get locally. Sometimes it's just a conversation. So it is important to give it a go. Looking into somebody's interests, you can have knit and natter, you can have music, you can have football, there's walking football. So again, it's another area that you can explore for the person to get support. A lot of the time that we think about when people have got cancer, we think about the services that relate directly to their cancer. Sometimes people don't want to be linked with services that have got cancer. So we do need to think more broadly. I Am Gadam is an independent volunteer charity that is based in Manchester. It's like your Bible. It has got everything. It has got how to do advocates. It has got housing. It has got friendship groups. So if you give them a little call, you can be guided where to go. The thing about Manchester and Greater Manchester is there's between 150 and 200 recognised languages in the whole of Greater Manchester. So they are a good resource sometimes when if you can't access services, they might be able to point you in the right direction. We've also got social prescribers, exercise groups. They are run, Age UK run Bolton's exercise and falls groups. So we don't need to just think about maybe sitting down. That's okay. They're all active. There is also active societies addressing that. And again, there is also societies for mental health and well-being. So Andy's Man Club is one that's worth advocating because it's just for men, and we know it's harder sometimes to get them to talk. They have a couple around Manchester, they're growing, but again, I think they're a really good initiative to point out and to highlight. Another one is Action Together that covers Rochdale, Oldham and Thameside. Again, if you go on their website, they have got their own little encyclopedia of where to get help and support. So these are all worth having mentioning or exploring in your local area. One last note before I move on would be to say that a lot of services now outreach from sort of hospice areas or wellbeing centres. The older people can think that that means that if you go to the hospice or link into the hospice, that's it. There's not that full understanding of that, like living well with cancer or a rehabilitation approach. So it is worth explaining to them that these services are just based there for sharing resources or admin purposes, but actually they're more for people who are living with cancer, not necessarily dying with cancer, to make sure they engage. So last but not least, I'm hoping to inspire you to use all the information that you have received today to help our older adults in their cancer journey. And for your inspiration here, we have got Iris at the top giving us a wave. She has reached the grand old age of 102. You may be aware that she's recently passed away, but she became a model at 90. So with the right support and with the right direction and with the right resources, people can achieve anything. Gladys is 102 underneath. She is actually a doctor and she is still practicing, and she does still ride that tricycle. So anything is possible. And these, obviously, I'm not going to lie, they're both American. However, meet Leo. Leo is a UK resident. Well, he was when I last checked. Well, last year he was definitely there, and he's 107. And on that picture there, I think it's Camilla and Charles, but he has seen World War II and he has gone through 5 monarch changes. So please do get in touch and ask us all questions if you need to. And I'm going to hand back to Cassandra now. Thank you for your time.
Thank you, Ada, for a very inspiring talk. Well, I would hope that I'll live to 104 and still be practicing, but maybe not. So now we've heard a lot from all our speakers, from all the different members of the MDT and what they could do in improving care in older adults with cancer. I think often when I go around talking about oncogeriatrics, people often tell me there's not enough geriatricians around, or there's not enough geriatric teams around, and geriatric teams are snowed under with inpatient care. But I think we've just heard today about the different things that different members of our MDT could do individually or part of a team to help improve the care in whatever ways, in little ways that accumulatively could translate into better outcomes for all the patients. So I will encourage anyone, if you've got any questions, to post those questions now in the audience chat. We'll come to it after this case discussions. But just to kind of illustrate a little bit more about real life practical tips, I thought we'll maybe discuss 1 or 2 cases depending on the time that we have and the number of questions that we get. But we'll maybe just take a case, and I'll invite all our speakers to contribute and say what they would do to help with this patient. So for first one, I think this is not uncommon. I mean, certainly within my role in managing lung cancer patients, we do see this, quite, I wouldn't say often, but we do see this regularly. So Mr. X, let's say, is a 79-year-old man with non-small cell lung cancer. He has been worked up for a planned treatment of 20 fractions of radical radiotherapy. His past medical history is illustrated, so heavy smokers, previous alcohol access, hypertension, type 2 diabetes, and potential cognitive impairment, though not diagnosed. His BMN's 19, 1 kilo weight loss over the last 3 months. It's just not eating quite so well. This is a list of medications. Again, not uncommon, especially with smoking being a key risk factor for lung cancer, but also a risk factor for cardiovascular diseases. So it's not uncommon that we see patients with this list of medications. And at the moment, he lives at home with his wife in a bungalow. So just maybe invite the audience, not the audience, the speakers, to say actually what can we do here before he starts his treatment? What are the key points that maybe we want to think about to try to optimize him before his treatment to improve his outcome. So I'll hand it over back to the speakers.
I don't mind starting on this one, if you don't mind. So I just had a few thoughts, one of them being his cognitive impairment. I might wonder if he's still managing to take his medicines or if he's got any help at home with taking them. And then also in terms of his medications, he's got a long list there, so he's definitely got polypharmacy. So I might want to do a medication review with him and look at all of the indications of the different medicines, see if they're still needed. For example, can't see a clear indication of why he's on aspirin from that past medical history. Things like omeprazole, is he still using that and getting benefit from it? And I know he's a previous drinker, but is it the case that he stopped drinking 20 years ago, so he's not necessarily needing thiamine? And then simvastatin, if it's just for hypercholesterolemia, if he's 79 and he's got other priorities and having side effects, then that might be one to stop as well. And he's on a number of medications which could contribute to falls risk. So things like ramipril, bisoprolol, and benzoyl they could all drop blood pressure. So I might want to do a lying and standing blood pressure just to check that he's not got a postural drop. And then just his anticholinergic burden. He's on amitriptyline, I can see. If that is for neuropathic pain, then maybe we could, if he's not having it anymore, we could stop it. Or if he's still having neuropathic pain, we can maybe try and swap it to something like pregabalin, which doesn't have an anticholinergic burden. And the other one, which so that amitriptyline has a score of 3, and also metformin has a score of 1. So I guess we could just check that his diabetes is well controlled, and he's on the correct medication for that as well.
Thank you, Sam. Yes, I agree with that. Yeah, he's on quite a lot of medications, and also I guess the other thing I noted was that he's on suboptimal doses of antihypertensive. So sometimes we do this little, as opposed to dietetics, we don't like the little but often type approach. Trying to treat with one tablet at maximum dose may convey more benefit in an older patient. Obviously, slightly different for the younger cohort of patients. Okay, Laura, do you have any?
I guess I'm probably a good person to crack on after, because we've mentioned looking at a diabetes review, and I think that's always really relevant. But also, looking at the kind of the weight history there, like a kilogram in 3 months doesn't necessarily sound like a lot, but then I think sometimes it's really important to look at other elements, so not just weight. Subjectively, does he look like he's lost more than a kilo in 3 months? Because sometimes fluid gains, if there's differences in kind of scales that have been used, or how they've been measured, he might have lost more than a kilo. So it's kind of looking at fit of clothing and things. If he's not eating as well, that in itself is a concern. So I think I'd be trying to establish a little bit more of like exactly what's happening there, getting some more details about like what his nutritional intake is and like how that's changed over recent time. Because with the background of diabetes, at some stage he may have been a very, very good eater and have been overweight. So his overall picture, it may be that he's lost like 20 kilos odd to get down to a BMI of 19. And obviously that's a much bigger risk than just 1 kilo in 3 months. So I think having that full clinical picture in terms of kind of weight history and appetite history and stuff is really important there.
Thank you, Laura. And I think one of the common things that we see in older patients as well with multiple comorbidities is they're often kind of, been told by families to eat healthily. And one of the most common problems is in diabetes.
It definitely, first job as a dietitian, I was in intermediate care, and there were definitely little old that were like, I'm not eating because it's I want to lose some weight, and it's like, you're 50 kilos. You don't need to worry about losing any weight. And they'd be like, all right, don't I? And they'd actually eat a bit more when she'd had a bit of a chat with them, or they'd be like, I can't have a chocolate bar. It's like, you can have a chocolate bar. Your diabetes is no longer a concern. Like, it's very well controlled because you're at a different stage in your life and you're not even on any medications for it. Like, I think that's the difficulty with diabetes, is the picture there can change a lot, and they'll go with the first health advice they have. Some people will stick to that forever, and some people will never follow it. So it can be really tricky to kind of address previous ideas of how they should eat that have kept going for a very long time.
Yeah, and I think sometimes it's easy as just highlighting it, that actually, yes, we acknowledge that you've got diabetes. That was important a long time ago to take, control your sugars, but actually your priority now is that through your lung cancer treatment. And then we can think about eating healthily afterwards. So I think that does happen quite regularly. I agree. Okay. Helen or Ada, I think Helen, you're going to take this one. Is there anything we can do?
Yeah. So I would just be interested from a 79-year-old, what are his actual activities of daily living? What things is he doing? What things does he enjoy doing? He might be somebody who goes out regularly, and we're going to have to factor in a potentially 4-week radiotherapy treatment, and that's going to impact massively on his activities of daily living. Does he have any commitments? Is he looking after elderly relatives, younger relatives? All that kind of thing we need to factor in. I think obviously what support he's got at home. Has he got any? Oh, he lives with his wife, sorry. But, what support has he got at home? Is his wife well? Maybe tentatively ask him about his memory. Has he noticed any changes in his memory? If he was amenable, because some people can quite take offence that, could we assess your memory? We can do very simple things. But it would be quite interesting to just get a baseline assessment if he's never had a baseline assessment. See what comes up. If it's not indicative of anything further, that's fine, but we can just let the GP know that he's had a cognitive screen. This is the score, so that going forward in years to come, the GP can look back and say, well, actually, he was that score on that particular day as it changed. If it's quite a marked score on his cognitive assessment, we would be then referring him out to the GP to request a memory clinic assessment. And then I think as well, sort of a 79-year-old, it would be the fatigue screen. Is he fatigued now? What levels of fatigue is he experiencing? Do that screen, and then we can repeat that screen through his treatment. Give him that information about fatigue management, about the normalisation of, sort of the fatigue in the older adults, and just, give him some little techniques and prompts that might help initially. We don't want to overload him with so much information. This gentleman's going to have lots and lots of different professionals involved. He's going to be given a huge amount of information in a very, very short space of time. That, is he going to be able to cope with all that? Why can his wife support? Can she not? So I think it's really interesting to know about him as an individual, what his lifestyle is like, and what he does day-to-day activities that are going to be impacted by this radical radiotherapy treatment.
Thank you, Helen. And I would concur with regards to cognitive impairment. I think undiagnosed cognitive impairment in the older population is fairly, high. And often when you ask people the question, "Oh, any problem with your memory?" and they say, "No, there's nothing wrong with them." But actually, what do you do every day? Oh, I just sit there and watch telly and I go to bed. And so, can you actually go to shops to get a pint of milk? Not done that for 2 years. So yes, of course, clinical history is very important and collateral history is very important. But sometimes just kind of thinking a little bit more about it, and given this gentleman's risk factor of previous alcohol access, I think it's really important, as Helen mentioned, to do a cognitive, at least a cognitive screen. But also, I think just to
Bear with us one moment, please. We're just having some technical issues. So cognitive assessments can be completed by a variety of different professionals. So it's not just one person's job. I think the most important things what we're saying, and it's the reason why we're all together today, is that it's looking at what the person needs and doing what we can to make sure they're getting the right input. So I think we'll move on the slide to see. Oh,
Sorry.
she's back.
Sorry, I'm back. I was just saying that obviously it's not all, a lot of people can do cognitive assessments, but occupational therapists do them quite frequently as well. So certainly a role for all members of the MDT. Okay, so let's move on. I'm just going to move on now with Mr. X. So Mr. X, halfway through his treatment, he becomes more sleepy with reduced oral intake. He's now sleeping during the afternoons. He's waking up at 3 o'clock in the morning and then getting up and down and, tries to go to sleep, but makes himself a cup of tea. And then, tries to doze off again. He feels tired all the time. And by this point, he's lost a further kilo of weight over the last 2 weeks. And his wife is starting to be a bit concerned about his mobility as well, that he's a bit more wobbly. So back to the speakers.
Do you want me to go for this one? I'll go first for this one. Okay, so obviously if he's halfway through his treatment, he's had 2 weeks of the radical radiotherapy. Unfortunately, radiotherapy is cumulative, so the impact of the fatigue is unfortunately going to get worse before it gets better. If he's become more wobbly on his feet, the chances are he's doing no activities or very, very limited, just literally getting to the hospital, having his treatment and getting home again. Depends on what time of day he's having the treatment and how he's getting to the hospital for that every day. Things like, I'm sure Laura will touch on it with regards to, is he actually managing to get any decent food into him? I think obviously sleeping during the afternoons, it's not a bad thing. It really isn't. A nana nap is a lovely thing to do. However, it's about how long is he actually sleeping in the afternoon. So if we're talking that he, gets himself comfy and 3 hours later he's still sleeping, that needs to stop. We need to look at kind of setting an alarm, waking him up so that he can, only maybe have half an hour to an hour of a sleep. Whatever duration will hopefully then lessen the impact at night, because obviously waking up at 3 a.m, if he's got, it's not a bad thing to try and break the cycle by getting up and moving around the house and making a drink. Is it a caffeinated drink? Because if it is, he needs to take that out. It needs to be a decaf drink. It would be interesting to do a fatigue diary with him to look at what his day-to-day activities are and when he's waking, when he's sleeping, when he's having treatment, when is he feeling worse in the day. And it would be about doing another fatigue assessment, compare it to the previous one and go with that with different, and sort of be able to then maybe push more of the fatigue information. He might be a little bit more receptive. It depends. The fatigue will then impact on his cognition. So he will become, sort of a little bit less aware, motivated and things with his, cognition. He'll be doing less. And they just start to withdraw at this stage. And this is where we're needing to hold him to get him through that radical treatment out the other end. And it's just everybody coming together as an MDT and trying to encourage the exercise. A little bit of exercise will help his sleep. He will feel a little bit more tired if he does a little bit more. But again, he's in the middle of the treatment. It's a really tricky time.
Thank you, Helen. And I think in the chat, Louise pointed out about the cognitive screen because he would be at high risk of delirium if he was to be admitted to hospital, if he becomes more unwell. But the hopes is that we'll try to keep him in the community. But despite that, I think, the fatigue could then manifest into hypoactive delirium. I mean, obviously, if he becomes dehydrated, not eating and not sleeping well as well. So thank you, Helen, for that. Laura, do you want to...
Yeah, so I think it'd be really important, like obviously the wife's really concerned, so I think like engaging the family members around trying to manage that situation is really, really important and could be really key. Like if he's struggling, he's not going to be the one who is initiating any food fortification or snacks and drinks. So again, it's probably looking at kind of what can we do to optimize what he is managing and make it as nutritional as possible, and getting a really good handle on like how much he is actually managing, so that if we think it's enough, can we carry on as we are, or do we need to look at getting him as an inpatient for the rest of his sort of treatment, or have you to potentially give nutrition another way if we felt like that was appropriate. But I guess it's having those conversations sort of early about like what do we think would be reasonable to do? Would we need to rely on nutritional supplements in this instance? It may be that is a good solution if he is struggling a lot with fatigue. So it would be kind of looking at that, but engaging him and his wife around that to sort of work out what would be best in terms of nutritional care and preventing further weight loss, because he was already very vulnerable, sort of low BMI before losing it so quickly in this last week, and making sure he's hydrated and that there's nothing else getting in the way there really of him eating. So if there is anything we can do that's an easy win, say managing pain or any other symptoms, like if he's getting any nausea or vomiting, then potentially that there may be different things we can do to help with those symptoms.
I think we also need to be aware that we need to look after the wife, because this is hard work and there might be other family members involved. So we just need to make sure that everybody is involved with the decision making and has the information, because if you have somebody getting up at 3 o'clock in the morning, you're going to be worried about them, and they'll get loads of phone calls saying, how are you doing? And then it can get a bit stressful because everybody means well, but then it's the same questions and same answers can be a bit difficult to manage. So we need to make sure emotional needs are met as well.
Sorry, most of the team seem to have been kicked out in this room, apart from me, which is a surprise to me, seeing as I've been one of the ones that have been left in here. But we have had a question about, or someone made a comment about, could a social centre for older patients be created to combat loneliness?
It does exist.
There are, like, obviously Age UK have different centres and things in different cities, and there are wellbeing centres. So there are things in place, and I guess everyone's loneliness is different. We've already seen that on the slide that Ada presented, and so like I guess there's no one size fits all for like a particular social centre might not encourage different.
We're having a great time at the moment. It's one in, one out at the moment with our technology. But that was a great question. And I think a lot of the times it's looking at broad terms. So they will address loneliness, but a lot of the times that language is not, which is understandable. It's got a lot of stigma about it. So you're looking for well-being, promoting health. There's a lot of the groups that were set up, especially community groups around COVID. So if your local area, if you can remember back what the flyers you've seen that were coming through, or what was on the local newspapers, etc., regarding the groups that were available around COVID times, they're generally a good place to start as well. Now, I am thinking that the whole team might be back in.
Excellent. I was just going to say that I'm going to take this time. I'm going to, at this point, ask actually Helen a question. Aside from the case, Helen, you mentioned about fatigue screening, and I'm just mindful that the team, the audience, may not be aware of any fatigue screening tools, and I just wonder if you maybe could share a fatigue screening tool that people could use.
Yeah, so I've recently done a quality improvement project with the team, and we use the Facet F. It's available online. It is probably a slightly more complicated fatigue screen, just because I wanted to look at not just one symptom, so it's a bit more in depth with regard to the questions. I think there was 13 questions on it, and you score it in a particular way, and it gives you an overall score at the end of it. That one, the scores were out of, I think it was 52 or 53. It's a few months since I did it, so I do apologise. And it basically was, the higher the score, the better the person was.
I think we've lost Helen and Ada, both our occupational therapists, at the same time. I'm so sorry. I can only apologize for this issue. Helen.
Sorry, I seem to be getting kicked out as well. So there are other ones that are just a 0 to 10, just a very simple Likert screen, which a lot of the EPROMs would use. So that would be 0 to 10, 0 to 100. So that would say, if you were going to do something as simple as that, you would just ask the one question. At the moment, how fatigued do you feel out of 10? They would circle a number. If it's below 4, that's fairly normal. That's a fatigue level for a normal person like you or I. Anything from 4 and above, 4 is kind of moderate, up to sort of 6, 7, and then beyond that is severe. And that at that point, they really need tailored, maybe further assessment, tailored interventions. It's more about kind of having a conversation, sort of very, very much individualized care. But there are lots and lots of fatigue screens out there. There is no one specifically for oncology necessarily. You just need to kind of find out which one works for you. I think if I had a different quality improvement project, I might not necessarily use the Facet F.
It looks like Helen's gone again. I'm so sorry for this. I think obviously there's some issues with Vimeo because we're all in different rooms, different places. Oh, there we go. Helen's back.
Sorry, it was just one that I knew that other teams within the trust that I was working with were actually using it. So I thought, well, it just builds a picture, and I just think it builds the evidence base. The main thing that came out of my quality improvement was that there are international guidelines, and international guidelines are all very well, but it's actually doing them that is the issue. And it's, I think because there's no set rules and regulations, it can be a little bit wishy-washy. I think it's just a case of doing it, trying it. If it doesn't work, try an alternative fatigue screen. But I do think it's really important. But as I say, I'm an OT, I would say that, I guess.
Thank you, Helen. Thank you very much. Okay, so very quickly, we'll move to, I think we've got 5 minutes. So we're going to quickly move on to this case and we'll wrap up after, because I don't think we've got any other questions in the chat group. Okay, so we've got 75-year-old female with lymphoma.
So she's planned for treatment with R-CHOP. She's a non-smoker, been healthy for most of her life. She's got chronic back pain from her occupation, no regular medicines or allergies. Her BMI is 34. She tripped while she was out shopping and she's got worsening back pain. She's seen her GP and they've given cocodamol 3,500, 2 tablets PRN. She's reduced her oral intake and is feeling nauseous, and she's very constipated, and now she's feeling unsteady, frightened, falling again, and walks with the aid of her husband's crutch.
Thanks, Sam, for taking over. So again, open up to the floor. So this is a fairly fit, you would say, 75-year-old who now obviously is encountering difficulties. So ahead of starting treatment, I'll open it up to the MDT to see what we need to highlight or what issues we need to try to optimize.
I think I don't mind if I go first on this one. It's really important to notice that she's that fear or frightened of falling again. It's really, really confidence. You can't buy a tablet for it, or it can't be prescribed or de-prescribed, as Sam's looking into them. But it's really important to acknowledge what's going on. When people have got difficulties with nausea, constipation, etc., and pain, they don't eat and drink as well, and then they stop doing things. So if it's hard for them to get to the toilet, or they're worried about waking up in the middle of the night, or they're worried about falling, they will stop eating and drinking properly. They'll limit their drinks, because then if they can't get to the toilet. And one of the things I would highlight is that if pain is a big issue, and I'm going to hand it over to Sam to suggest, but we need to make sure that the pain goes through day and night, because we all tend to get up for a little trip to the bathroom during the night, but it's to make sure that there is appropriate pain control, that the person can be as independent as they need to be. And obviously, this is very, very common. If you see somebody with a mobility aid, ask them where they've got it from. They're very resourceful older people, so they get them for everywhere and anywhere, and it might necessarily be the right one for them. So just ask, where did you get it from? And they are entitled to be assessed and would be provided free, definitely indoor mobility aids. Depending on where you live, they will also provide outdoor mobility aids. So I think I might hand over to Sam to talk a little bit about the pain.
I'd first find out if she'd found that cocodamol helpful in managing her pain, and that might explain whether she's sensitive to opioids. And if she was finding it helpful, one of the side effects of codeine that's really happens a lot in older people is constipation. So one option you could do is think about starting some PRN laxatives, or another thing to think about is maybe we could swap to a different pain medication. So something like a buprenorphine patch, because it's not taken orally. In general, we find it a lot less constipating for patients. And if she's got this chronic back pain, that might help take that away. Might be useful to be on a regular paracetamol to spare the amount of opioid she's needing, or sometimes if she's got pain every so often, she might need some top-up short-acting pain relief like PRN oral morphine, but again, that's very constipating, so we have to try and stay on top of those bowels. Also, if she's got back pain, as she's an elderly female, she could be high risk of having osteoporosis. So we'd work out her FRAX score, see what her risk is, and if necessary, we can send her for a DEXA scan or start her on treatment if appropriate to prevent any fractures.
Thank you very much. So yes, I agree that it's a good opportunity to also visit her bone health with the FRAX score. Okay, BMI of 34, Laura. Is that happy or?
Yeah, well, I mean, I was going to jump in with talking about the fibre side of constipation, and also like making sure she's hydrated, because we've already talked about like potentially dehydrating yourself so that you don't have to run to the toilet as often. That is definitely something I've come across. I remember working as a dietetic assistant way back in the day, meeting a 102-year-old, and she told me, I will dehydrate myself if I want to, thank you very much. I don't want to have to keep ringing this call bell to get someone to help me go to the toilet. So I think constipation is going to be made worse though by dehydration, not eating enough at all, and not eating enough soluble and insoluble fiber, and also not being as active. So she's worried about falling, she's not going to be doing as much. So obviously there's like the nutritional side to the constipation as well, which obviously there is options to manage with other extra medications, but we don't really want to add medications in to treat constipation if we could potentially just avoid the constipation or do some nutritional changes. But yeah, a BMI 34, she is overweight. In the older adult, we wouldn't necessarily be recommending, though, somebody who is overweight, obese, to be losing weight. And like if she is losing weight gradually, then we might accept those losses, but we would be really wanting to make sure that they're losses of only fat mass and that they aren't impacting on muscle mass. Because she's larger, she's going to be more at risk of losing that muscle mass without realizing. So she might be, because she's of a bigger size, she might be happy with losing some weight. So there may be a barrier there to wanting to improve that oral intake because of the nausea. So in terms of kind of things that you can do, kind of like day-to-day practical things to help with nausea, stuff like getting some fresh air, or certain flavors. So peppermint and ginger are quite natural ways of improving kind of feeling nauseated. Avoiding cooking yourself, so the food smells don't cause that nausea as much, can be really helpful. Or potentially just trying to choose colder options, to go in for things like sandwiches and other kind of packed lunch foods that might help overcome the nausea, because we don't want her to become malnourished. That's the important part here. She's going through treatment and we don't want her to be malnourished. That isn't going to give a good outcome. So yeah, she's overweight, but like, yeah, that's not the concern here. We need to keep an eye on what's happening there. And she may have lost weight down to that BMI already. She may have started off as a BMI of 40 and now she's 34. And so there's already losses going on that are a bigger concern. So I'd be looking at her overall intake and looking at
Cassandra, I think it's also important to note that this is pre-treatment planning, and our audience are the people who are working in the community have got a very valuable insight. A lot of the patients tell the doctors when they go, well, you'll know yourselves, that just tell them what they want to hear, especially when they're pre-treatment. And this person is requiring a lot of support and input from the whole team. So we do need to look to optimize them as much as possible before they undergo treatment, because they're going to be working hard with their treatment.
Agreed, Ada. Thanks, Laura, as well for your input. And I agree. I think everyone has a role to play, and I think increasingly we're saying actually it needs to start from primary care, and there's certainly a role for primary care as well as secondary care and community services. And today we've obviously heard of the role of our other colleagues, rather than just the doctors, but also the role of all our colleagues in optimizing care for all the patients. So I'm just going to draw that to a close because we are 2 minutes past 2. First of all, I just want to thank all our speakers for an excellent talk, for all your excellent talks, rather, and all the enlightening advice that you've provided us. And hopefully all of us have a few tips to go away with to put into practice in our clinical practice when we get back to work. And I would like to thank the audience as well for coming. Thank you for spending the 2 hours with us. I hope you found this useful. I would say that obviously if you we'll be very grateful for your honest feedback. If there's anything else you would like with regards to kind of education around the care of older patients with cancer, please do let us know and we'll see what we can put together. I will also pick up on Doreen's actually last point about, I think, Ada, this might be in relation to what you said about cancer services, and they may not always want to be linked to services related to cancer. So thank you, Doreen, for that. All right. Okay, so I'll draw that to a close. Thank you very much, all. Thank you for coming. And hopefully we'll see you again soon at our next webinar. Thank you.